attend on the Wednesday morning, there is a permanent link to a YouTube video of this meeting available on our website on the community engagement pages. So when I send out the slides from this meeting, I'll include a link to that for you, and please share it as far and wide as you can.
Absolutely. And could I just, before you start, Julia, just plug that we have a health lecture on the 18th of March from our modern matron in mental health, who's going to be talking about mental health in acute hospitals. So that's on the 18th of March at 6 p.m. And he's going to take questions at the end as well.
Okay, that's brilliant. Thank you all very much for that. So I will now officially open the meeting. For those of you who've just joined, you haven't missed anything. I'd like to welcome Carla Jennings Priest, who's going to, at the last community meeting, there were a number of questions around the vaccination programme, and we said we would try to get somebody, and Carla is our somebody. Carla, would you like to just introduce yourself to the meeting, please?
Hiya, yep, my name's Carla, as Julia said. I'm working on the vaccine programme. Initially, I was the clinical lead nurse for all the Shropshire, Telford and Wrekin sites, and then I've just recently been moved to as operational manager just for the Telford site.
Okay, that's brilliant. And we have actually got some slides in the community cascade that relate to that. So what I'll do is when they come up, I'll hand over the floor to Carla to take any questions that you might have. I'm going to give an advance warning that my link, I'm in my office at the moment, it isn't brilliant. Paul mentioned, you know, the technology. If I have problems with the link, I will come out and use a different machine, but it means I don't have a camera on that, so you'll just have my photograph. But it's not for any other reason other than the Wi-Fi signal isn't very good here. So if we go into Cascade, as I've said,
can everyone see the slides on the screen? Is it sharing?
Yes.
Yeah.
Yes.
Okay.
Yes.
Thank you.
Need to go to present. Oh, that's it. Cool.
Thank you. So this is, in essence, the same slides that we give to our staff, so that you're receiving, you know, the same updates on the key issues that staff receive. So if we go to the next slide now, can I ask Kate, can you monitor if there's any hands that I miss or any comments that come in that need that I don't, because I'm not ignoring you. It's just sometimes difficult to see, although I can't see. Thank you very much. So this is just a little bit more about our maternity transformation programme. We are hoping for the next meeting that we'll be able to invite somebody from the maternity team, so what our head of midwifery, to come and talk to you about this. Obviously, the key issue for us at the moment is the Ockenden review. This will be reported at our public trust board meeting, which is tomorrow at 1 o'clock, and it will be on every public agenda until you know, we've dealt with all the immediate and essential actions. Very good news is that we've gone into partnership with Sherwood Forest Hospitals just in relation to maternity. We're still in the partnership alliance with University Hospital Birmingham, but for maternity, because Sherwood Forest are a sort of exceptional trust in this area, they're linking with us on maternity for about 12 to 18 months, looking at different aspects of the maternity service that we deliver. As far as Ockenden is concerned, actually, I said it's on our trust board tomorrow. If you look at most trust boards up and down the country, you'll find the Ockenden report features there, because in addition to the immediate and essential actions for SAF, there are actions that are actually spread across the whole of the NHS. So all hospitals with maternity units are considering those recommendations and drawing up action plans. We are working with external people as well as our own team to make sure there is that oversight and independence as we deliver the plan. It says 7 immediate and essential actions, but as ever with the NHS, they break down, and in total there are 77 actions. So it's a lot more complex than it appears on the face of it. But they break into those major areas of clinical practice, culture, patient experience, governance, and training and evidence. So this is still a really key issue for SAF, and one of the differences, if you like, to previous reviews is that we're working much more closely with families that have been affected, and involving them in the whole assurance process, which I think absolutely is the right and proper thing to do. If we go to the next slide, which from memory is also about maternity, this is just some of the key areas that SAF Maternity Services have introduced over the past month following the release of the first Ockenden report. We know there is going to be a second report, and that's going to be hopefully later this year. So we've appointed 2 more matrons, a head of midwifery, that's in addition to our director of midwifery, Nicola Wenlock, and an audit midwife, because clinical audit is really important, making sure that we are meeting the standards that we set. There's now named obstetricians and midwives in place as fetal monitoring leads. This is a big area for SAF, but also for other trusts. Fetal monitoring is so important, and it is so easy not to get it right first time. So it's really important that you've got checks and balances in the system so that you can detect problems early on in the late stages of pregnancy. Now twice daily ward rounds on the delivery suite with a consultant obstetrician. So if there are any births which may have, on the face of it, seems straightforward, but actually haven't progressed as expected, there will be a consultant available to give advice and ensure that early action is taken. And there is looking at the culture issues. There are now safe space sessions so that colleagues can talk about concerns that they may have, whether it's on an individual case basis or about the way that that a service is being delivered, so that we can make improvements quickly, and that colleagues feel confidence to raise their concerns. We're working with Midlands Partnership Foundation Trust, that's the mental health trust, because it's really important that we treat our families with compassion and respect, and they're helping us frame this in a much better way, because sometimes if you read the Ockenden report, which is a harrowing read, it's clear that mums haven't always felt that they've had that compassion and civility, and sometimes staff say we haven't expressed it to each other either. The Maternity Voices Partnership, that's a really important group. That's representatives of past and present service users, and they've been involved in a number of different initiatives recently, including we're redeveloping the maternity web pages so that it's much easier to navigate, and that people can get information easily, and that that it's accessible and available anytime, night or day. And the National Bereavement Care Pathway is being implemented. We've now got a second bereavement midwife. That's one of the issues that mums felt they didn't always receive the care that they needed after they'd suffered a bereavement. And clearly it is a tragedy for any family, and the second midwife will mean that there is now sort of care available to all those families that need it. So all of those are really important things, and it's all these small things that actually will make a big difference. And if you're a user of the service, or you have members of the family. These will probably, one or more may have some resonance with you. I mean, I've had 2 children through the hospital and 3 grandchildren, and certainly there are things that I can recognise. So I think this is moving us forward in the right direction. If we go on to the next slide, this is really exciting news. I don't know why it's called Badgernet, because that sounds like it should be on Country File or something. Badgernet is our end-to-end web-based maternity service. So this means that whether you're in the hospital, whether you're in the community, whether you're at home, whether you're in Cornwall or whether you're in Scotland, you can access your records. This is being rolled out. It means that both mothers and clinicians can get the information, and there will be a single pregnancy record wherever the mother is, because we have had incidents, and Donna Ockenden has picked up on, where mums have gone out of the county and their records haven't been available. So whoever's just joined, could you go on mute, please? That's great, thank you. I mean, one of the things that, sorry, we should have said at the beginning, if you're not speaking, if you could go on mute, because otherwise you get an awful lot of feedback. So this is a really exciting thing. We've started it, and we're anticipating that by June it will be completely rolled out. We're now sort of training up users and super users and administrators in the hospital, but it will revolutionise the way that mums can access their pregnancy records. So that's all, really positive stuff. I think that is now the end of the maternity update, and I think now we might be going, if we go to the next slide, we're going into COVID. So I'll just start a little bit, and then I think the next slide is about the vaccination. So March the 10th was a year since the first COVID case was detected in Shropshire. Oh, there is a question about the Ockenden review. How is SAF supporting the mental health of those parents? Yeah, that's a very good question. I mean, there are a number of helplines, and what we have said to families, if they have any concerns, to raise it with their midwife. If that doesn't address the issue, there are independent people that they can ring in the care group. I know that there are people that have gone out of county for maternity services. I think the only thing that we can do is demonstrate by our actions that people can have confidence in the service that we're providing. And I wouldn't want, if somebody felt that they didn't have that, I wouldn't want to try to persuade them, because I think actions actually speak louder than words, and will be public. There's a lot of data published around birth outcomes. Embrace is one of them, and it's looking at that data and making that judgment for yourself. All mothers have choice, and if they choose to go out of the county, then that is absolutely their choice. If they want to talk to somebody about it, whether it be a midwife or another health professional, we're absolutely delighted to do that.
Julia, can I just jump in there
to
say that there is an increase in the perinatal mental health support for women in our footprint. We received a message the other day from Pathway Coordinator for Staffordshire and Shropshire Perinatal Mental Health, saying that they are building a bespoke service for the area and around baby buddies. So if anybody has anything that they need to talk to, the first person to talk to is your midwife, but your midwife will be able to put you in touch with the appropriate people to help, I think, is the message that needs to go out there.
Absolutely. I think that work came directly again out of Ockenden, because there were issues that we missed with mums that had mental health issues. I think the question is slightly different, but mums that had mental health issues that we missed, and those mums felt unsupported. And I think absolutely, as Kate has said, there are now much better support systems in place for mums that are anxious about their pregnancy for whatever reason. But in terms of the place of delivery, that is absolutely the mum's choice. And the mental health support group service wouldn't try to dissuade them from that. I think, you know, that has to be the mother's choice.
There's a note here. Some of the mums from Powys and been left without the support.
This support is available to anybody that delivers at or is in the delivery kind of pipeline with SAF, Joyce. So if mums have sort of mental health issues that they want to raise, they should raise it with their midwife, and if that isn't answered satisfactorily, then go directly, contact somebody directly at the unit, and they'll put them in touch with that service. It is a relatively new service, to be fair. So going back to COVID, we still are caring for a high number of COVID patients, but that is decreasing. At one point, we peaked at almost 170 inpatients, and now we're down to sort of below 50. So the number is decreasing, but, and you know, you can never say that without the but. We do need to remain vigilant. There are new strains, and I won't go into Carla's territory, but PPE, whether you're working in the NHS or whether you're going to Sainsbury's, it's an important issue, and we all need to still be observing that. We continue to receive mutual aid support from Robert Jones and military sources. Robert Jones, along with other NHS organisations, including SAF, are moving back to the recovery of services, so that help will be ceasing. We've created extra critical care capacity, which again we're no longer requiring, but at least we were able to do it, and we know that we can do it should we need to again in the future. And the routine activity, which was temporarily stepped down, is now being ramped up again. And just, you know, a thank you to our staff really for everything that we're doing. So if we go on to the next slide. I think there we are. At this point, I'm going to hand over to Carla. Carla, do you just want to take us through this, and then we'll open it up to ask anyone so they can ask you questions? Yep, no, and I'll go on to mute.
So just to give you a bit of overview from our one of our weekly meetings yesterday, so far we've just hit the 200,000 mark for the amount of vaccines that we've given in Shropshire, Telford and Wrekin. We have hit 100% of our over 80 cohort. Our over 65 cohort, we're at 96.6, and we've just opened up the 55 age bracket cohort, and we're already on 42%. The age 50 and plus will be opening up in the next week or so, and we'll be doing the letter drops, and we're trialling a text message service as well. So as we're getting into the younger generations, a lot more IT savvy, we're hoping that the text message would help. Obviously, we're working across the whole of Shropshire, Telford and Wrekin. We've got the PCNs as well, and we've got the vaccination centres. So we've got the Telford International Centre, Shrewsbury Indoor Bowls and Ludlow Racecourse, and then we've got Robert Jones, Agnes Hunt have now gone over now to a dual vaccination centre. So they're moved from a hospital hub to a vaccination centre. So they'll be using the Pfizer and the Oxford vaccine there. Shrewsbury Hospital Hub is now back open, so it was temporarily closed, so it's a training centre, and now we're opening back up this week for our second vaccines, and that'll be open up until the end of April. I've just updated about your vaccines there. It's a little bit higher than that third point, and your percentage of local people. So we're obviously still going through our frontline colleagues in line with the Green Book, and the people that are in that cohort are quite clearly outlined in there. Obviously, we have had quite a lot of what's the word to say? some people coming back not agreeing with it, but we've got to go in line with what the government are saying, and they're the people that are telling us who we can open up the vaccine to and when. And then we've got the extremely clinical vulnerable as well, which can book in through the national booking system. So if they get their letter from their GP or a text message from their GP, they can then get onto the national booking system through the .gov.uk website, and they can do that themselves, and they can pick which is their closest centre to go to as well. And then we've got a roving vaccination team as well. So they go 2 days a week at Shrewsbury and at Telford, and they're looking at all the eligible inpatients. At the moment, I mean, it's good for us that actually we haven't done a lot of those because they've already been done. So that's really good that people are being proactive and getting the vaccines done before they're becoming acutely unwell. But if there is any eligible patients whilst they're in hospital or long stay patients, we are vaccinating them whilst they're an inpatient as well. I'll pause there, and if anyone wants to fire any questions.
We have got a couple of questions, Cara. The first is, what percentage of those invited for a vaccination are refusing? I don't think that is the first one, but we'll take that one first. Okay, and that came from Neil.
So I can just let you know, I'm looking after just Telford International Centre at the moment, so I can just give you their figures. Yeah. So since we started mid-January, we've delivered just under 27,500 vaccines. And the people that actually booked in and cancelled, we've just got a 2,000 difference. So the uptake is really good. DNAs, we do a follow-up process as well if there's a reason why they haven't turned up, or they've obviously been admitted to hospital, or there's been some other issues why they haven't turned up. We do attempt them the following day, and we do 2 phone calls to try and get them rebooked in as well.
Okay, and what's happening with second vaccinations where the patient was contacted by a GP practice? That's from Jackie.
So if they were vaccinated a GP in their first vaccine, they must go back to the same place they got vaccinated, purely because it's either Pfizer or Oxford, and we can't mix the 2 vaccines. So if you went to the Telford International Centre and had Oxford on your first vaccine, that's where you need to return to afterwards, and that's the same for your GPs as well.
Okay, and then is it Anna, how do people who do not have English as their first language get assistance when they are getting the vaccination? I believe there is a leaflet to read first. Anna is from the Polish Association.
Yes, there is. It's on the .gov.uk as well. There's different languages, the leaflets, and also, like Julia said, there's leaflets that we can help and assist with if you actually get to the vaccination centre as well.
And we actually held a session, I think it was last Wednesday, with members from the Polish community, didn't we, Kate, with Laura talking about the vaccinations?
Yes, we had quite a useful meeting, and obviously Anna and Ella from Polski Glos were both there, where we were looking at the reasons potentially why the Polish community might find it more difficult to want to understand the information that we're putting out to them, but also what the reasons behind them thinking that having the vaccine wasn't a good idea. So we are continuing to work with the health economy team on that, and that's being led by a woman called Kate Manning from Shropshire Telford and Wrekin Sustainability Transformation Partnership. But there's a lot of information coming down centrally from government in different languages. What we're trying to do is develop something locally that will be particularly useful for our Polish communities, because we've got Polish communities right the way across Shropshire. And a suggestion's come out this morning that perhaps we should have a special Polish clinic where we look at having Polish speaking vaccinators so that they can answer questions. I'm not sure how possible that is, but it's certainly something that's being looked at as of this morning. So we will do whatever we can to make sure that the system responds in the best way to that.
Okay, thank you, Kate. Sorry, Jackie, it doesn't seem that we answered your question. Apparently, Jackie was aware that you go back to wherever you had your first vaccine, but she wants to know what is the process for contact when the patient's first vaccination was at the GP. I think what you're saying,
the
Jackie,
GP will contact you.
Yeah. The GP will.
Yeah.
Okay. And Cal, who is our workforce diversity lead at SAF, as just commented, we've developed short video films as well with our interfaith groups. Are they on the, where are they available from, Kath? Are they on the website?
Yeah, they'll be on the website. They're on YouTube as well. So we've talked about the Polish language, but lots of different languages as well. And there's leaflets in Punjabi, Gujarati, Urdu as well. So there is a lot of work going on to kind of reach out to communities where there is a bit of concern around taking up the vaccine, just to really encourage them. And myself and Priya George, who's a GP from Market Drayton, actually we did a couple of interviews with Radio Shropshire last week as well, just trying to kind of address some of those concerns and kind of encourage people to take up the vaccine when they get the call.
Okay, thank you. I've then got Jackie's asked, what's the position for frontline workers who refuse the vaccine? Carla, are you able to?
Well, it's obviously it is their choice. They don't have to have the vaccine, and if they've got any medical conditions that stop them from having it, with anaphylaxis shock and things like that. But we are obviously promoting it, and we have got to about 80% of frontline colleagues. So the uptake is actually quite is good, but we can't force it upon people. Unfortunately, it's their human right to say no as well.
Yeah, I mean, anecdotally, I am not aware of many staff that have refused. No. In fact, staff are sort of non-frontline staff are chasing hard to get their vaccine because, you know, they're keen to be covered. I can see a hand up, but I can't see whose it is. Is it yours, Hannah? No. I can't.
No, I can't see because I'm presenting.
No, it's gone down now.
It's just gone down now.
But Lynn
sorry, it was me, and I put it down. Thank you.
Okay, thank you. Lynn asked a question. TI Telford International Conference Centre asked patients to remove their mask and put a paper mask on from an open box, which they find very concerning, as lots of people are touching the masks in the open box. At other vaccination centres, you're allowed to keep your own mask on. Can the process at TIC be changed? So, Carla, that's interesting because we have the same issue at SAF, and we were making people take off their own mask. But then there was a change, and now if people come in with a mask, they're allowed to leave it on, because I know the receptionist outside Trust Headquarters was doing daily battle, but that requirement has changed now. So
yeah. So if I give you a bit of an update, so initially everybody that came into the vaccination centre at all centres or at all hospital hubs had to change into one of the surgical masks. So we were following the SAF protocol there with COVID. Then it was that they could wear their own face covering, whether it be their own handmade one, a surgical mask or whatever they've bought off the high street. And then we got a little bit more guidance that it's best practice to make sure that the surgical masks are brand new and are replaced on entry to the centres. So at Telford International, yes, you've got somebody holding the box for you, but the process should be that you take your dirty mask off, whether you want to throw it away or keep it. If it's your own bought one to wash, that's fine. You hand gel, so then you've got clean hands, and then you pick one mask out of the box. So although there is lots of people touching the boxes, they've all decontaminated their hands and mitigated any risks. Obviously, if they're using the table to put their items on and things like that, we will wipe down the tables and between each patient.
Okay, so that's the latest guidance. So
yeah,
you know, that is what it is.
Yeah.
Neil has asked, what is the percentage of the total population needed to achieve herd immunity through vax?
Oh, that's quite a hard question to answer, really.
I haven't seen an answer to that.
No,
so
I mean,
I wouldn't like to guess.
No, I wouldn't guess. I can say that you're around about 70% protected after your first vaccine, and then it will go up to around about the 95% on your second vaccine, depending which vaccine you have.
Slightly different
but that's,
question. I think what
yeah,
Neil's
but
saying,
per
how many of us
person,
need to have it.
But I can't answer. I don't know.
No. I haven't seen any definitive response to that.
And I think until we get to that point where we have a herd immunity, then they'll start looking at figures and the positive rates, if they hopefully start to reduce. But I don't think we've actually got there that far really yet to actually get the data, to be honest.
No. And then it says, I think as well there may be a reluctance, even if they do know the figure, to issue it, because some people might think, oh well, I'm not going to bother, I'm going to wait until they get to 70% and then I'll be covered anyway. And
obviously, even if you still have your first or your second vaccine, you've still got to follow your social distancing, continue to wear your masks, still in line with like lockdown rules and things like that as well with the government, so you still need to do that.
Can I ask a question, and then I'll come to Liv and Frank's question. I don't know whether it's Liv or Frank or both. But my question is, if you have say a Pfizer vaccination the first time, do you get a Pfizer vaccination the second time?
You do, yep.
Okay.
There's no data out at the moment to say that it's safe to mix.
Okay, great.
So you should always have the second, same as the first.
The same as the first.
Yeah.
And then the question from Liv and or Frank is, what is the position with people with anaphylaxis? As it appears some people on Facebook are getting the runaround as 119 are referring back to GP and GP are referring back to 119.
Yeah, we've heard about this quite a lot. So there isn't, the protocol did change, and actually it's if you've had a severe anaphylaxis that's needed hospital admission and you've been in ITU and you've had to be intubated, if you have a side effect or a allergy to penicillin, you can get the vaccine. 119 should be going back to the national protocol, which is what all providers should be doing. But I do believe that they are kind of sending people round. So the best advice I can say is to speak to your GP, and if GP's happy for you to have it on what they know of your medical background, then you can book in through the national booking system, and you can do that online yourself.
And is there a preferred vaccine if you've had even a mild anaphylactic shock?
It's all dependent on a clinical decision, so it'd be best to speak to the GP. And obviously, if you do want to book your appointment, you can. And then when you get to the centre, we do ask all the appropriate questions, and there's a medic on site as well, so they can double check with them and get clarity whilst you're on site.
Okay, that's brilliant. Thank you. Dave just made a comment about it's important that patients need to be assured that people treating them are safe. Everybody that treats a patient has a very strict PPE, so no patient is being exposed, even if staff haven't had the vaccination, which I think is really, really low numbers anyway. But all patients, because safety is a two-way thing. That the patients could be infected and asymptomatic, so strict PPE is observed, so there isn't any risk of transmission. And if we get an outbreak, which it sounds very alarming, but that just means 2 people in one area, one ward, that contract COVID, then that is managed as an outbreak, and we respond very quickly and take very high infection prevention and control measures to contain that.
I'll just let you know, Julia, as well, on the door at this vaccination centres, we have a crib sheet. So every patient that comes through is asked if they've got any symptoms, if they've got a temperature, are they fitting well on that day? And also if they've had COVID in the last 4 weeks, they then get turned away and have to rebook their appointment. So we do have checks at quite a lot of stations throughout the process.
Absolutely. I mean, to be absolutely clear, everybody should have a vaccination unless for some health reason they can't. And that's unequivocal. Okay. Any more questions for Carla? I think that might be the last. That might be the last vaccine one. Can we go on to the next slide? It is. So, any more questions before we let Carla go? If not, Carla, I'd like to thank you very much for your time here today. It's been I've learned things that I didn't know, so it's nice to have it. I don't want to say from the horse's mouth; it sounds a bit rude, but it's having that first-hand experience, and a big thank you to your teams, the vaccinators, both at Telford but across the county, because it is the only thing that's going to help save us and
a little light at that tunnel at the minute. So
can I just jump in there again to say that Carla's very kindly offered to come along to the community engagement meeting to give a presentation with maybe other members of the team. We're not quite sure yet, but certainly there will be a session on the COVID vaccination at the community engagement meeting on the 24th of March.
That's the 2-hour session. We're also hoping to get Nicola Wenlock from maternity to that if she's available. So, book your place now. Carla, thank you very much indeed, and we'll let you get back to the important work of jabbing.
Thank you.
Thank you.
Thank you.
Thank you. Okay, so the next slide is really about. It's just to share with you that we do recognise this has been for our staff the last year has been a year like I've never known before in my 37 years in the NHS, and it has taken a toll on staff. Some staff have been living in their garages or in caravans parked on their drive so as not to risk contaminating their families. Some have sent families away to be with grandparents, and now it's almost like the adrenaline rush of COVID kept people going, but now we are seeing that a lot of our staff have been affected. So there's lots of support that we offer to staff, including counselling services at the Hamer Centre and over the telephone, peer counsellors, mindfulness sessions. But we're also now introducing a Wellbeing Wednesday where we walk across both sites, randomly or by invitation, just to talk to staff about how they're feeling, and anything that we can do to help them. And one of the things, we have a weekly newsletter called Chatterbox, and we have a wellbeing wheel in that, and it sounds, but actually it's quite simple. Every day, just try to carve out 10 minutes or so for yourself, to just clear your mind and just be. Try to take 30 minutes of exercise, even if, park your car a bit further away and walk from the furthest car park rather than parking as close as you can, which seems to be. Nutrition, hydration, make sure you drink plenty, 2 litres a day, and make sure you're eating properly, because when you're under pressure and it's busy on the wards, that is one of the things that you can miss. And resilience. One of my director colleagues used to have an expression which was put your own oxygen mask on first. And that's right, because if you're not looking after yourself, it is really hard to look after patients. So there's a lot that we are doing in lots of ways, as well as the Wellbeing Wednesdays. We've created lots more open spaces for staff to go and get some fresh air, to take a break outside, because the healing effect of green spaces can make a terrific difference. We've put marquees up, because obviously with social distancing, the dining rooms aren't as accessible, so that teams can go out into a courtyard, and even if it's raining, they're heated, and the seating. So as well as mental well-being, there's also physical well-being, and we've got a couple of big projects coming on to introduce Captain Tom Gardens at one at Princess Royal and one at the Royal Shrewsbury, both for staff and when we're in a position that we ever have visitors back on site again that can access, just to take time out. So a lot going on to support staff, and that's really important because they've been in the thick of this day in, day out for over a year. If we go on to the next slide, this is just a little bit about the Hospital at Night team. I'm not going to go through this in great detail, but just to let you know, because this probably is a team that the public generally aren't aware of. They operate at night from 7:45 in the evening till 7:30 at night. So if our medical staff are busy in theatres or in A&E, because we do see peaks at that time, we have the Hospital at Night team that can be called out on both sites. They're actually based in the site, but they can be called to wards to go and support ward staff with patients if they have immediate needs. So they're all trained in advanced life support and in paediatric basic life support. They're part of the cardiac arrest team. So if there is a cardiac arrest anywhere in the hospital, they will attend and support the ward staff in dealing with that. And as well as the nurse practitioners, there are clinical support workers. And as I say, these are probably invisible, but it's they play a really important role and provide support to nursing and medical staff across the patch.
Hi, Julia. Have you seen the comment from Dave? Are staff able to take a bit extra time for mental and physical health while being at work?
Subject to the needs of the service. Obviously, if the ward is really busy, staff can't walk off a ward. All staff have breaks that are factored in, and we, as I've said, we started to provide outdoor areas close to wards, because actually the dining room may not always be convenient. So at PRH, for example, we've just introduced a royal dome outside the AMU, which looks like a big glass golf ball. It's 8 meters in diameter, and staff can go out and sit in there. They didn't have anywhere. They had to go into a little cramped staff room. So they'll be able to use that winter and daytime, winter and summer alike. All staff have their breaks. If somebody is, we do have wobble areas. So if somebody is feeling, you know, I do need to just go, then obviously they need to just go. But that has to be, you know, done with the ward manager or their colleagues, because we can't leave wards sort of short staff. But yes, wherever possible, absolutely we do that. And we've created areas. The League of Friends on both sides have been really helpful, letting our staff access their areas, their restaurants, because both of them are quite close to wards, and they can go and, you know, get a drink and chill out. I've lost the presentation. Has everybody else lost the presentation, or is it just me?
No, it's gone.
Reshared it. I don't know why it's gone, but I will reshare it. There we go. Is that come back?
Yeah, that's it.
Yeah.
That's great. So if we can go to the next slide. So this is just some key developments in our division. So surgical division are restoring as much activity as possible. So we know how important that is. Throughout the pandemic, we have managed to do the sort of emergency and life-threatening cases, but the last, since January, there have been some delays in some of our non-priority cancer cases. Now, every cancer case is a priority, but some are more rapid and fast-acting than others. Some have had delays getting diagnostic tests done, MRI and CT, and we've increased capacity on both sites to deal with that. So what we are now doing is staff that have been redeployed to help out in the kind of COVID areas are now returning back to their normal workplace, and we are starting to address those issues, dealing with obviously the higher priority ones first. In women and children's, we've covered a lot of this really in the earlier update, and we're again, their very last comment is around increasing the number of urgent and long waiting patients for surgical procedures, because their theatres were limited as a result of COVID demand. Medicine and emergency care, we've the MAID event, and you know what, I've forgotten what that acronym, but it's about delivering emergency care event that involves all our partners, looking at how we improve flow through the emergency departments. And, you know, nurse staffing is still an issue for us, but the good news is that the AMU on the RSH site is at full establishment for the first time. It's probably in about 4 or 5 years. It's always been a really difficult ward to recruit to, but it, you know, it's brilliant because that means we don't have to rely on agency staff. So a big well done to the ward and to the recruitment team in workforce that have got that up to full speed.
It is a multi-agency discharge event.
Thank you very much. And because the problem with ED is often it's our discharges on the wards that are blocking up ED, because we can't transfer patients out because there isn't a bed to go to. Then in clinical support services, which are pathology, radiology, pharmacy, therapies, there's some updates. We've got physiotherapists to support the Better Births initiative. And anybody that's had a baby will recognise pelvic floor exercises the minute that they say it. Business cases to replace our current systems and introduce digital pathology, which means we'll move away from paper reports floating around the hospital and a step closer to an electronic patient record, and some joint pharma outcome pilot success. So again, looking at the discharge service and working with the community to make sure that follow-up actions are being picked up on. Lynn mentions the nighttime duty staff. If a patient's family is aware of the problem on the ward at night, who would they contact when a particular ward is not prepared to listen to them? You can always go through the clinical site manager if you have a concern. They are the kind of organizer at night of services. So the clinical site manager. The other thing is you can always ask to speak to the on-call consultant of whichever specialty that it is that you have a concern about. But those would be the two people that I would go to. It's the clinical site managers who decide, you know, where to hospital at night are most needed. They coordinate all the cardiac arrest calls and the fire calls, and they make sure that flow is working through ED. So they're another invisible team that absolutely are essential, daytime and nighttime. If we go to the next slide. So this is just some changes. So we had, I'll start with the last two first. Both Brian Newman and Tony Allen have left the board. Brian had been with us for nearly 7 years, and Tony for just over 2 years. They were associate non-executive directors. Now, technically, you're not, the trust board consists of 5 voting execs, one of whom has to be the chief exec, one the medical director, one the nurse director, one the finance director, and another. You then have a chairman and 5 non-executive directors. We had a number of associate non-executive directors, and when posts become available, they then moved up into full non-executive posts appointed by the Secretary of State. Brian and Tony had both had full posts and had then sort of stepped down to associates, and as part of a sort of slimming down, if you like, of the board, they've now left. But both of them, you know, made a very valuable contribution while they were with us, and I echo, you know, our thanks to them. And then Dr. Aaron Menon has been appointed as an associate specialist of anaesthesia, and importantly, I mean, being an associate specialist of anaesthesia is important because that's a very hard to recruit to specialty at the moment. Everybody's after anaesthetist, but he's also going to be the senior associate specialist clinical tutor. And that's a really important role. We need to have clinical tutors that are taking care of the education and ongoing development of our associate specialists. It attracts them into the organisation in the first place if they feel there is career development and career progression. So it's a really important role, and some of them may go on, you know, indeed to qualify as consultants if they choose to do that later. So this is a really important role, and one, you know, that we should be very pleased that we've managed to recruit. If we go on to the next slide, this is just something that we're going to introduce, just a thank you to staff, and actually not always the staff that might first jump to mind. So I mentioned earlier about we'd had the peak in critical care patients, and we needed to almost increase our critical care capacity by another 50%. We also needed to introduce, and we're doing it at both sites. We did RSH first because it's the bigger unit, isolation pods. Because previously, without the isolation pods, it was very difficult. In fact, it was impossible to have COVID patients and non-COVID critical care patients in the same unit. So with the isolation pods, which really do look like something out of Star Trek, we can now care for all our patients in one physical area with the right staff all around them. In order to do that, we had to move critical care into day surgery, which we did, and then installed the BioQuell pods, and also sort of upgraded critical care, and everyone's now moved back. And it was a fantastic feat, and that was a big thank you to everybody involved in that, because that is helping keeping our most seriously ill patients safe. And we'll be doing the same at PRH the week after next. We've had to work, it's an external company that does the fitting, but and there's a huge demand, as you can imagine. Ian Morris-Jones, a thank you to Ian. He's our head of portering in the facilities team. Along with everyone in the NHS, there's been a huge increase in clinical waste, and that's largely face masks. I mean, everywhere you go, you see these blooming blue face masks like tumbleweed. But the face mask has to be disposed of as clinical waste because they could be infectious. But that meant that our normal delivery, our normal collections have had to almost double in order to deal with it. But our contractors have had the same demands from everybody else in the NHS. So we did get to a situation where there was a real problem. And Ian made sure that we kept the wards moving and that there was no backlog of clinical waste on the wards, so kept the situation safe. Some very good news about Professor Jason Casray. Jason is our head of fertility services. He's been at the trust a long time as well, and he's now been appointed by the government to the board of the Human Fertilisation and Embryology Authority, which is, a really prestigious appointment and a feather in Jason's cap, and indeed in SAF's. And then Claire Woolsgrove, who's our quality matron. Claire will arrange for British Ironworks to donate 100 rainbow daisies, which are beautiful. There was so much interest in them that staff have said they'd be very happy to buy them. British Ironworks have let us have them at a discounted price, and any profits are going to SAF charity, the staff Small Things Big Difference staff wellbeing funds. So and they are beautiful things. I've got one in my office which is my pride and joy. So but again, it's just, we do lots of little things to say thank you to staff. Our response volunteers regularly take around thank you bags. We've had huge donations from the community. Yesterday I was in Bridge North at the Grange care home, and the residents had walked around the garden in Alec Captain Tom to raise funds for SAF, and they brought more chocolate oranges and sugar rush sweets and bottles of wine, which we'll find a safe way of getting to staff. And it was just lovely to see these lovely people that had done this really kind thing, and it is such a boost for staff. I think one of the, as well as COVID driving us more to using technology, it's also been such an outpouring of support from the community on a scale that I've never seen, and I can't tell you how much staff appreciate that. Before I go on, Claire's raised a question about the isolation pods. You had not received them, but we're still, the isolation pods are in place at RSH, and so that isn't an issue anymore. We weren't mixing what we were using different areas in order to treat sort of red and green patients, but particularly during the spike, that was becoming increasingly difficult to do. So we were using areas like recovery and HDU in order to keep them separate, but it meant that staff were being stretched across lots of different places. So will the isolation pods also come in useful in the future? Yes, they will, because we have other infectious diseases. It's not just COVID. Flu is infectious, and if somebody is really poorly, I mean, again, in ITU, we have really rapid air ventilation changes. I think it's 25 per minute. It may be more than that. So there is, and everybody in ITU wears the kind of highest level of PPE. So it's not the surgical face masks, it's the hoods and the full gowns and aprons and gloves and boots. Whereas, and similarly on our COVID respiratory wards. But yes, Sarah, the answer is they'll come in very useful. I mean, they're expensive. I think we've got 6 and it was £250,000. So, but you know, they're well worth the money. So if we go on to the next slide, this is really just a sort of what's coming up in the next month. So de-escalation plans that we've already talked about, and restoring elective activity as much as we can. Actually, you can tell by looking at the visitor car parks, they're starting to get busy again. And redeployed doctors. So our junior doctors will be going back to their normal departments because they've been helping out in the sort of COVID areas. The COVID vaccination programme continues, and I think Carla's updated on that. Work to refurbish A&E at RSH is about to start, and that's a huge piece of work. A&E at RSH has been criticised by the CQC for many different aspects. The issue is it's a 1970s building, and it needs significant investment to bring it up to today's standard. However, we've got the SDEC, same day emergency care modular outside it, which has helped relieve the pressure on that. We'll be able to provide much better facilities for patients visiting, and there's a mental health assessment area, there's designated paediatric area at the that will be at the front to keep peds really separate. There'll be much better facilities for patients that are waiting, and the flow should be better. But it's a big piece of work and it won't be completed till this time next year. But the department will have to stay open throughout, so that's going to be difficult. Work will continue to recruit to senior positions, and sorry that I'm reading the Mallings Health, the Ironbridge Suite at PRH will be opening. That's another modular building. It will look lovely, though you wouldn't realise it was modular when it's completed. That's going next to the old Malling Health walk-in centre, and that's going to provide a hot desk and administrative space for colleagues, hopefully so that we may be able to move some administrative staff out of clinical areas to free up some clinical space. And then Ward 20, the Cataract Suite at Copthorne, is now open after I think it's 3 years of in gestation. But that's really great news, and I've had a walk around. It's a fantastic facility. Maternity work, we've already mentioned it, and then although the final word is the COVID situation is improving, but the hospitals and our colleagues are still under enormous pressure. Please continue to be kind, considerate, and patient. Everyone is trying to do their best, and it's important that we support each other as much as possible. And this, you know, please look after yourself and your colleagues, and that applies to you as well. I think that there's one more slide, which is just, that's just some of the help. I mentioned it earlier. In addition to the Wellbeing Wednesdays, we have Care First, which is a number that staff can ring anytime, night or day, and it has trained counsellors to speak to. We have the Team Prevent advice line, that's our occupational health service. There's HR advice and support. We've got Freedom to Speak Up Guardians. We've got a My Occupational Health Wellbeing page. We've got trained mental health first aiders. We've got a peer-to-peer listening service, the Hamer Centre one-to-one counselling services for staff affected by COVID, and that's normally for patients with cancer or other long-term conditions. But Captain Tom, NHS Charities Together, funded counselling sessions for staff affected by COVID, and they've been very well used and very well received. And then the End of Life Care team also are going into ward areas to support teams that have had difficult COVID experiences to deal with. And again, that was funded through Captain Tom as additional support. We put in a successful bid for that. Thank you, Claire. Yes, it is excellent news about Ward 20, and for those of you that have been involved, as I say, you'll know this has been a long time coming. So that is the last slide. It is 12 o'clock, but I'm happy if there are any questions that anybody wants to raise before we sign off, to take any questions. A reminder before you go that it is SAF Twitter Hour, Living Well with Cancer, tonight at 7 o'clock. It is, there is another 2-hour community session on the 18th, is it, Kate, where we will have 24th, where we will have Carla to do a more in-depth presentation, and hopefully somebody from maternity. And you know, if there's any issues that you would like to raise, if you contact Kate before that, we'll see if we can sort that out in time for the 2-hour meeting. It's a bit difficult for these meetings because they're only an hour, but for the 2-hour meeting, then you know it's much more over to you. And not
forgetting the health lecture on the 18th. That's the event on the 18th.
And that's from our mental health matron, Mike Ford, who'll be talking about mental health in an acute hospital, which is a really important issue, and there will be an opportunity. And I think that's at 6 o'clock, isn't it, Kate?
Yes, 6 till 7, and then it will be followed by an hour on Twitter if you've got any questions that we couldn't cover in the session.
Excellent. Okay, well, thank you all for your very kind...
Hang on, Jackie's got a hand up.
Okay, I do beg your pardon, Jackie.
Oh, hi there, Julia. First of all, thank you for sharing all this positive work that you're doing, and the excellent, work that you're doing in such difficult situation and circumstances. It's something I just wanted to raise and bring to your attention. I do some work with Karen Breeze, and I actually sit on the dementia steering group, and it is a steering group. And one of the things that alarmingly Karen raised with us at the last meeting was obviously the hospital prides itself on being a dementia-friendly hospital, and I know the great work that she does, but she provided us all with a list that looks like this of all the outstanding signage, equipment, handrails, clocks, all sorts of things that she's been trying to get for, oh gosh, the last sort of 10 months. Now, this came as a bit of a shock to me because I do a lot of work around dementia, and my concerns are safeguarding, falls, wandering, and inequalities for patients who've got cognitive impairments and or dementia. But for example, there are toilet signage. There are 88 signs that need to be placed around the different sites of the hospital. There are 59 toilet seats. There are 134 clocks, and the rails, 85 rails outstanding. And I know this is not the forum for you to raise that, but I need to bring it to your attention.
Jackie, I'm very glad that you did. Nobody will believe that we haven't rehearsed this, but Karen's list is going to our capital planning group next week.
Brilliant.
For funding. She's been around with Will Nabby, the head of the Associate Director of Estates. He's looked at it all. He's provided her with costs for it all. It now goes to capital planning, and it will either be funded from NHS capital funds or from SAF charity funds, but it is all in hand. I think part of the problem was Karen wasn't entirely clear on the process, and actually it is a bit convoluted, but with any request, she knows it now, so I'm sure she's going to be a regular. But yes, so it's been costed up, and it's going to the capital planning group for.
It's great to hear, Julia. I wouldn't be doing my role as a person sitting on a steering group if I didn't. We promised to all raise it, and so I'm glad to.
Drop Karen a line and ask her how because she'll be able to confirm. It's going to capital planning.
Thank you very much.
You're very welcome.
And we've got Claire Humphreys.
Yeah, Claire.
Probably a question for Hannah Roy. Before the pandemic, we had volunteers going into the ophthalmology department to provide information about services in the community for people with visual impairment. Do you have any idea when we might be able to look at getting our volunteers back in the department?
So what I will need to do is that we have to risk assess all the volunteer roles that we have within the hospital at the moment. So we do have some volunteers that do come in. They are our response volunteer roles, but they're not going into ward areas at the moment, primarily for their own safety. But we do have volunteers, so it will be about us liaising with ophthalmology and yourself to try and risk assess the role that the volunteers are carrying out. The second stage of it is anybody that's coming back to volunteer, we have an additional kind of measure which we risk assess their risk around COVID. So although people are having their vaccines and is really positive, we still need to make sure that the volunteer is safe and we're not putting people that are high risk in volunteer placements at the hospital at the moment. So do you want me to link with you outside of this meeting? Yeah,
please, that would be great.
Let me note that down. Thank you.
Thanks.
Fantastic. And I think, you know, just to echo what Hannah has said, but I mean, with ophthalmology, it's largely an outpatient. There's no inpatient element to it, so that may be a lower risk group that we could look at. Okay, well, if there isn't anything else, it's just left to me to wish you all a happy Wednesday, and hopefully see you either on the 18th, either tonight, the 18th, the 24th, or same time in April. Thank you very much.
Thank you. Thank you. Bye-bye.
Bye.
Thanks.